Hello, my name is Jeff Reese, and I'm a pharmacist here at the University of Iowa College of Pharmacy. I also practice in the geriatric clinic at University of Iowa Hospitals and Clinics. And joining me a little bit later will be Leo Marcini, and he's a dentist here at the University of Iowa College of Dentistry. And we will be co-presenting on management of comorbid symptoms that interfere with sleep in the older adult. Neither Leo nor I have anything to disclose. So let's start talking about insomnia. So insomnia includes both difficulty initiating sleep as well as staying asleep. While difficulty initiating sleep is common experience by many people from time to time, the problem of staying asleep is often more common as people age. We encounter complaints regarding both difficulty falling asleep and staying asleep from many patients we see in geriatric clinic, and we want to share with you the approach we take to address these issues. So let's start with the case. We have MB, and she's a 74-year-old female residing alone in her two-story, 100-year-old farmhouse. Pretty typical of a rural Iowa patient that we might all be caring for. She complains today of inability to fall asleep and stay asleep for more than 2 to 4 hours at a time. She has tried the over-the-counter product Tylenol PM, but she couldn't tolerate the dry mouth that it caused. And she's here at clinic today requesting a sleeping pill. So let's look at a couple of MB's medical conditions. So she's a relatively healthy 74-year-old. She has hypertension, which is treated to goal with a couple medications that are listed there on the slide. She also has osteoarthritis. And she's been using for that over-the-counter ibuprofen, which you can buy in the 200 milligram size, and she's been using quite a bit of that per day to manage her osteoarthritic pain. She has also gastroesophageal reflux disease, which is a fairly long-standing concern of hers, for which she uses Tums, an over-the-counter antacid, which contains calcium carbonate as needed. As I said, all of these medical conditions have been fairly long-standing. Otherwise, she's pretty healthy and she's cognitively intact. So what are our options? How do we respond to MB's sleeping concerns? So I've listed 4 potential options that a person might take. Some might prescribe Ambien or Zolpidem, which is a commonly marketed sleeping aid in the United States. Comes in a 5 and 10 milligram size. That would be one option. Option 2 would be to tell her to keep using the Tylenol PM. That dry mouth that she might be having, she'll get tolerance to that, and then she'll be able to continue taking that medication. So some might recommend that. We also might consider a history and physical exam. I think that kind of goes without saying for any kind of complaint, but I think certainly with sleep that's a good idea, so that's an option. Or we could just tell her that sleep problems can be a part of normal aging, that sleep architecture changes. So how should we respond? Let's just go through these options one by one. So let's think about option 1, Ambien or Zolpidem. First thing we want to probably realize is that Ambien is a Beers criteria medication. So the Beers criteria, as I'm sure many of you are aware, are a listing of medications that might be considered inappropriate for use in older adults. Many of them have inherent risk, side effects, if you will, that make them a little bit more dangerous maybe in the older adult, and quite frankly, some of them are dangerous in all age groups. But the reason why Ambien is on the Beers criteria is we have a long-standing history of this medication causing problems such as delirium, falls, and there's this weird side effect that people have, and they have it in all ages, not just the older adults, but this strange syndrome of they do things at night that they have no recollection of. So people have told me in clinic over the years that they think somebody's getting into their house and cooking food in the middle of the night. And in reality, they're doing it, but they have no recollection of it. So they're kind of sleepwalking, doing this stuff, and some of it's quite dangerous. We've had people wake up outside, not realizing how they've gone there. We've had people notice shopping bags from a convenience store that they'd actually driven to in the middle of the night with no recollection. So Ambien has some inherent risk, and these risks are similarly concerning for other medications in that class. So I think most of it would say initially this probably wouldn't be the best choice for MB. especially living out alone in a farmhouse out in the country. So the other sleeping pills that I've mentioned are similar to Ambien. For completeness, I've tried to list a couple different classes of meds here. Not that I'm recommending these. In fact, I don't recommend them. The benzodiazepines are listed there for your information. Those are strictly the benzodiazepines that actually have an indication for insomnia. However, all the benzodiazepines have been used for insomnia over the years. The other ones, the non-benzodiazepines, we often call them the Z drugs because many of them have a Z in their name. We have Zolpidem, which is, or Zolpidem, I'm sorry, which is Ambien. We have Lunesta, and then we have Soma. So those drugs are, or I'm sorry, Sonata. Those drugs, in fact, are all very similar in side effect profiles, and in fact, nightly use of any of them would be considered risky in older adults as well as other age groups as well. What about option 2, Tylenol PM? Well, strangely enough, Tylenol PM, or one of the ingredients in Tylenol PM, is also listed in the Beers criteria. The ingredient that gets it a ticket on the Beers criteria is the diphenhydramine. Diphenhydramine is an over-the-counter antihistamine, commonly known as Benadryl. And diphenhydramine, while it does cause drowsiness and sleepiness, it has inherent risk with it as well that have, as I said, earned it a place on the Beers criteria. It is highly anticholinergic. So anticholinergic drugs tend to be drugs that we try to avoid in older adults because of the side effect profile that goes along with the anticholinergic effects. Things like dry mouth are very common. Sedation, which in this case is one of the indications for using Tylenol PM. But it also has with it other anticholinergic side effects like dizziness, lightheadedness, falls. And there's also a cognitive component as well. Many times the anticholinergic drugs work in the brain, in the cholinergic system, and actually cause cognitive impairment. So because of the cognitive impairment and risk of falls, it's kind of a risky drug to use in older adults. What about option 3? That kind of history and physical exam. Now certainly, I think most of us, kind of going without saying, would do this. What we're really trying to do here is to find out what is actually going on with MB and to try to figure out if this insomnia that she's complaining of is actually a symptom of something else that could be best addressed by treating that other condition. So we look at things like her physical status. So, she had complained of osteoarthritis. So what kinds of pain does she have? And looking at her other medications, certainly medications can be awakening or stimulating. So if she's on medications that might have side effects of agitation or stimulating, or even things like caffeine intake can all have an effect on a person's sleep. So yes, I think doing this complete physical exam would definitely be an appropriate option. What about option 4? So this is one where we do some education about how sleep can actually change and our sleep architecture changes as we age. Now, with this option, by educating her about this, I don't feel like we want to dismiss her complaints and just say, well, that's part of getting older. It certainly is not. However, there is always a place to educate people about how our needs change as we age. So certainly, most will find as they age, they do not sleep as long. They cannot sleep as long a periods of time without waking up. There's actually a lot of evidence to support how our sleep architecture changes as we age. And sometimes just letting a person know that this is the new normal for them helps them to gain acceptance and willingness to try some of the non-pharmacological options that I'm going to talk about later in the program, things we call sleep hygiene or some of the cognitive and behavioral approaches that can really be as effective or more so than the pharmacotherapy options that we have. So listed here are conditions associated with insomnia. Some are classified as true sleep disorders, while others are more medical conditions that can affect sleep quality. We're going to go through these one by one, kind of talk about them, talk about how these conditions may interfere with a person's sleep quality, and then maybe give some treatment options for how we might treat those. conditions which often present as sleeplessness. So let's start with restless leg syndrome. So restless leg syndrome, if you've ever talked to a patient, is a very, very uncomfortable experience. It commonly interferes with a person's sleep and often their partner's sleep. If the person, in fact, often the person that is sleeping with them is often one of the ones that complains about it. It often occurs alongside of another condition, another sleep disorder, which I'll talk about on the next slide, which is periodic limb movement during sleep, or PLMS, which is a slightly different disorder but involves the same types of jerking movements of the limbs. Of note, we should always be checking labs when we hear of these complaints, because these conditions can also be manifestations of a couple of deficiencies, including iron, B12, or folate, and this can result in the leg restlessness and the limb movement. Correction of these deficiencies is always going to be needed to be done preceding any other therapies. We want to do this to make sure we don't end up with polypharmacy, because it's really easy to start piling on medications for these conditions without really getting to the underlying cause. So PLMS, which is diagnosed by a sleep study, is, like I said, very similar to restless leg syndrome, and I will kind of talk about them together since the treatments of those two are very similar. So I mentioned earlier on the previous slide that iron deficiency is one of the common causes of restless leg syndrome. So when a person comes into clinic and complains about this jerking sleep or jerking limb movements or this very uncomfortable feeling in their legs that they just have to get up and walk and walk and walk to relieve, the first thing we're going to do is we're going to do some iron studies to find out, are they anemic? And quite frankly, iron deficiency anemia can be very common in older adults, especially those living alone. They may not be eating very much in the area of iron-rich foods, and iron deficiency anemia can be very amenable to treatment with oral ferrous sulfate, and in severe cases with extremely low iron stores, we can certainly do even intravenous iron. But it responds very well to treatment using one or two of those modalities. Once we get the diagnosis of iron deficiency anemia, we start the iron. If it's orally, we like to add vitamin C to that because iron is best absorbed in an acidic environment. And you noted that MB had GERD, so she was taking an antacid. So, if you take iron with an antacid, it doesn't get absorbed as well because you're changing the pH of the stomach there. So we want to give that iron with some vitamin C. If it's given orally, if you're giving it IV, you don't need to worry about that. And we'd recheck the iron stores in about several months just to see how we're doing. Once her iron stores were repleted, we can back off on the iron. One of the complications of iron that many will know is constipation and stomach upset, so we want to avoid that if possible. And we don't want to administer iron longer than what we need to. So after we've either ruled out the iron deficiency or we've corrected that and then we still have the problem, we would shift into the non-pharmacological treatments. So there's a lot of things that have been studied. However, there isn't a tremendous amount of evidence on any of these. However, because of the relative low risk of all of these non-pharmacological treatments, I think most of us feel very comfortable starting with that. And even if we end up going with pharmacotherapy, we always want to maintain the non-pharmacological treatment because many of the treatments that I'm going to talk about on this slide are just really, really good practice anyway. So the first one is mental alerting activities. So you might say, well, wow, why would you want to get somebody all cranked up before they go to bed? But we're actually talking about things such as working crossword puzzles or anything that causes your brain to kind of engage and think and maybe take your mind off of the sensations that you're feeling in your legs. So crossword puzzles, probably avoiding things that are computer generated just because, and I'll talk about this a little bit later, there's a growing body of evidence that looking at an electronic screen can actually affect your sleep architecture as well. So probably not, computer games and those kinds of things, but old-fashioned crossword puzzles, Sudoku, things like that can be very helpful of getting a person to kind of relax and not think about their legs. Exercise is very important, in fact, sometimes the only treatment that patients have told me works is if they're having this sensation in their legs, is they just have to get up and walk. They just have to walk it off. Exercise during the day can be very helpful, but however, we don't want to recommend vigorous exercise right before bed because it does interfere with your ability to get restful sleep. Certainly, avoiding medications that are going to aggravate restless leg syndrome. And this is something where I think we haven't always been as diligent about looking at what medications might actually be either predisposing us to restless leg syndrome or certainly aggravating them. So I've got a list here of some that might surprise some. Certainly, we think of the dopamine blocking drugs, things like the antipsychotics, because we do suspect that this restless leg is associated with dopamine deficiency because the drugs we're going to talk about in just a moment are all dopaminergic agents. So certainly a drug, like an antipsychotic that blocks the effects of dopamine would be negative. And it's true, antipsychotics certainly do aggravate restless leg. But we also find that many of the antibiotics are also going to aggravate restless leg syndrome. And these are mostly antibiotics of the SSRI, the selective serotonin reuptake inhibitor class, as well as the selective norepinephrine reuptake inhibitors and the tricyclic antidepressants. They've all been shown in study after study to exacerbate restless leg syndrome. However, there is one drug, bupropion, which is actually more of a dopaminergic type antidepressant. It does not exacerbate restless leg syndrome, and in fact might help improve some symptoms. However, it is problematic to give bupropion at bedtime because of the stimulating effect of dopamine at bedtime. So, if a person needs an antidepressant, giving bupropion during the day probably makes a lot of sense, and maybe switching someone's antidepressant as well. Antihistamines, such as diphenhydramine, the active component in Tylenol PM that we talked about earlier with our case, certainly can be exacerbating of restless leg syndrome as well. So we've tried the iron, making sure the deficiencies have been cleared up. We've tried some non-pharmacologic agents, and we're still having restless leg. So what do we do about that? Well, now, and really only now, after those have been attempted, is it appropriate to consider pharmacologic treatments? I think a lot of times we often rush to try pharmacologic treatments because sometimes we feel like convincing a person to try some of these non-pharmacologic things or even taking the time to educate people about them is a lot of work, and it's easier just to give somebody a pill. However, we know that those non-pharmacological agents will work in a number of people, and they won't have to result to the tablets and the pills that we have to recommend. And quite frankly, the medications we have are not without their side effects either. So the agents listed on this slide are the main ones we use for this condition. And they're called dopaminergic agents, or alpha-2 delta calcium channel ligands are the two common groups. I also have carbidopa-levodopa there, which is actually a dopaminergic agent as well. That's known as Sinemet, which I think was originally used for restless leg, and we still sometimes use it, but more of an as-needed, not as an every-night basis. If you need a medication for every night, we have the two classes of drugs there to work from. The alpha-2 delta calcium channel ligands are gabapentin and pregabalin, also known as Neurontin and Lyrica. The dopaminergic agents are listed there, pramipexole and ropinirole, that can be used. Like I said, we don't use the Sinemet as much because it's increased risk of a complication of dopaminergic therapy called augmentation, which I'm going to talk about a little bit later. So how do we decide whether to go with something like gabapentin, which we would probably use before we'd use pregabalin, for a couple reasons. Number one, because it's a lot less expensive. Lyrica is more expensive, and gabapentin, we have lots and lots of experience with it. We have a lot of dosing flexibility, and many of us are very comfortable recommending gabapentin. So how do we determine whether we use that kind of drug, the alpha-2 delta, or do we use the dopaminergic drug like ropinirole or pramipexole? So on this slide, we have the compelling indications for when we might use one or the other. So if in light of not having any compelling indications, however, I think starting with gabapentin seems reasonable, again, due to the less risk of augmentation, which I'll talk about in just a minute. Note, however, there are side effects to consider with gabapentin, and it is very important to taper the dose of gabapentin up slowly to minimize side effects. So I've mentioned augmentation a couple times, so I'm going to kind of try to explain that. So augmentation is something that occurs when we use dopaminergic agents such as pramipexole or ropinirole. Now, and it's kind of a counterintuitive thing, and it usually happens after a person has been on the medication for a little while and maybe their symptoms start to get worse and they think, well, I think I need a higher dose. Because the thing with all of these medications, the dopaminergic agents and the gabapentin and Lyrica, we have a lot of dose flexibility, and so we start at a low dose always in older adults, and we gradually taper it up. But with augmentation, what happens is, they lose symptom control, so we add some more, increase the dose, and it gets worse. And whenever you suspect that, whenever you have a person whose symptoms are getting worse despite appropriate dose of the dopaminergic agent, and remember this only occurs with pramipexole and ropinirole, it's time to suspect augmentation. And really what you need to do is you need to taper them off of that and discontinue that medication, and then try one of the drugs in the alpha-2 delta calcium group, like gabapentin or pregabalin. Okay, let's shift gears here and talk about sleep apnea. So this is another sleep disorder. And again, if sleep apnea is suspected, we do have to have polysomnography or a sleep study done in order to get an accurate diagnosis. So this can occur as obstructive or cortical, or central, and both of them can be very, very disturbing of sleep, and they're associated with lots and lots of other disorders, especially cardiovascular risk. So sleep apnea is a very, very serious condition, and if a person is suspected of sleep apnea, appropriate testing is definitely in order. So for treatments for sleep apnea, regardless of the type, there's a couple lifestyle approaches that we can attempt. Certainly avoiding alcohol, certainly in the evening, but even there's some evidence that excessive alcohol use earlier in the day can still aggravate sleep apnea. Avoiding central nervous system depressants, things like benzodiazepines, like some of the sleeping pills or anti-anxiety pills, or anything that's sedating like antihistamines or opiates, they can all aggravate sleep apnea. And they should be eliminated from the regimen if possible. The gold standard treatment for sleep apnea is continuous positive airway pressure, or CPAP, where someone is fitted with a mouth and nose piece, which is hooked up to airway, which applies constant oxygen airway pressure, and it works extremely well. I will tell you from talking with many people that have had sleep studies and have had CPAPs recommended, probably getting used to the device is probably the hardest thing for people. And if someone comes to you and says, I can't handle that device they sent out, have them come out and try a different setup for their face, because there's lots and lots of different designs of the mouth and the nose piece that hopefully everyone can find something that works for them. There are oral appliances that are marketed if they absolutely can't handle the CPAP, but the evidence isn't as strong with those. So getting the CPAP and making sure they don't give up on it just because the first get-up that they sent out didn't work for them is extremely important. We're going to shift gears here now, and my colleague will be coming in to talk about bruxism.
So now we are going to continue our lecture, and I would like to thank Dr. Raist to have started such a good way this lecture, and now we are going to talk a little bit about bruxism. Bruxism has been defined by the classification of sleep disorders since 1990 with different definitions. So the first definition in the 90s defined the sleep bruxism within the category of parasomnias, or disorders that intrude on sleep but are not associated with complaints of insomnia or sleepiness. As a stereotyped movement disorder characterized by grinding or clenching of the teeth during sleep. Well, that definition evolved to a second definition by the middle of the first 20,000 years. In 2005, it was categorized as a sleep-related movement disorder and defined as an oral parafunctional activity characterized by tooth grinding or jaw clenching during sleep, usually associated with sleep arousals. That definition was in place for about 9 years, and on 2014, that definition was expanded to include also bruxism that happens during the non-sleep time. So general bruxism is considered now a repetitive jaw muscle activity characterized by clenching or grinding of the teeth and or by bracing or thrusting the mandible. So now we are not only talking about a sleep disorder, but also something that happens in your non-sleep time. What's the bruxism etiology? The most recent hypotheses on the etiology of sleep bruxism support the roles of the central and autonomic nervous system in the genesis of oromandibular activity during sleep. So, more specifically, sleep-related mechanisms under the influence of brain chemicals and maintenance of airway patency during sleep may increase motor activity underlying the genesis of sleep bruxism and rhythmic masticatory muscle activities, the motor manifestation of sleep bruxism preceding tooth grinding during sleep. So, although we have a good sense that bruxism is not generated by local factors like occlusal teeth occlusal factors, we don't know yet what are the intimate mechanisms that explain bruxism, and so far there is no cure for bruxism yet. So what we can do is to manage the condition. Bruxism can vary on the way it manifests from one individual to another, and also in the same individual in different time periods, the manifestation can be drastically different. So some patients can have long periods without grinding, and some patients will grind a lot at small periods of time. So the way it presents is in the teeth where surfaces. So we have some severe cases like the one we have now in the slide, where most probably the patient is grinding for many years in an intense way. And that kind of manifestation is not rare, but it's not also common. We have much more commonly presented patients that are mild grinders. So we have some amount of tooth wear, but not as severe as the case we are presenting in the slide. So actually, by doing polysonographies, we can identify 7 different steps on the bruxism process. So the first thing that will happen is a sleep arousal. And after that, we are going to have a rise in heart rate of about 25% in the electrocardiogram. And after that, we will have an increased jaw opening muscles activity, mainly in the suprayoid muscle. And then we can have a large respiratory breaths and a rise in systolic and diastolic blood pressure. And finally, we will have the rhythmic masticatory muscle activity that is the most important feature of the bruxism, that bring teeth together and grind them. So, and by the end, the patient will swallow, finishing the cycle. So that's how it happens step by step when patients are sleeping. So in the sleep bruxism type of bruxism. So how can we diagnose that? Dentists usually are the frontline providers diagnosing bruxism, just because of the consequences of bruxism that we can see on teeth. So the International Classification of Sleep Disorders lists two main factors. The first one is presence of regular or frequent tooth grinding sounds occurring during sleep. So how can we know that? Well, we will need patient reporting that or a sleep partner reporting that on behalf of the patient. And on top of that, we have the presence of one or more of the following clinical signs: abnormal tooth wear, consistent with reports of tooth grinding during sleep. So that's what we usually see during oral exams. And sometimes patient can present with transient morning jaw muscle pain or fatigue, or temporal headache, or jaw locking or on awakening, consistent with the reports of tooth grinding during sleep. So the diagnosis is done on the basis of clinical exam and patient or sleep partner report of sounds of grinding during sleep. Those are the most used criteria for bruxism diagnosis in the clinical setting. In the research setting, though, currently most researchers are looking at polysonography studies, where you do have the amount of bruxism and how it happens and how much it happens, in which frequency and intensity during sleep. So it's not uncommon to see different patterns of sleep, of tooth grinding. So in the left side of the slide, you can see a severe bruxism pattern where more than half of the tooth structure have been worn out. And in the right hand of the slide, you can see a more moderate pattern of tooth grinding, where just the tooth cusps were grinded off. And when you ask the patient to bite together, then you can see how those patterns fit, showing that the source of the loss of the tooth structure loss is the mechanical attrition among tooth surfaces. It's very important to differentiate how the tooth loss have occurred, because we also have other sources of tooth loss, like chemical loss, and that can be confusing to who is not really familiarized with the bruxism pattern. So other features that can be found on patients, on bruxist patients, are the linea alba, that is this small white line in the patient's cheeks. That's an hyperkeratinization caused by the friction with teeth surfaces during the grinding habit, and the indentation of the side aspect of the tongue caused by the friction with the teeth during grinding too. And of course, as talked before, you can see the absence or the loss of tooth structure caused by the contact with the antagonist teeth, reducing the contacting surfaces. So how can we manage bruxism? How can, as far as there is no cure, how can we reduce the consequences, protect the dentition, and reduce patients' pain when pain is present? So looking at a systematic review done last year, we can see that almost every type of oral appliance is somehow effective to reduce sleep bruxism activity, with a potentially higher decrease for devices providing large extent of mandibular advancement. So almost any kind of intraoral appliance that are placed between the lower and the upper teeth can have an effect on reducing the symptoms and the bruxism activity. All tested pharmacological approaches, and those were botulinum toxin, clonazepam, and clonidine, may reduce sleep bruxism with respect to placebo. And the potential benefit of biofeedback and cognitive behavioral approaches are not supported by the current evidence. And the only investigation providing an electrical stimulus to the masseter muscle during bruxism was effective to reduce the sleep bruxism activity. So usually we can reduce bruxism and control its consequences by simply using an oral appliance. However, it's important to note that it's not treating bruxism, because it's not going to preclude any patient from grinding. It's just grinding over a surface that can be replaced instead of grinding over tooth surface that till now we cannot replace in a similar fashion. So this is one paper showing that the use of flat, plain, and hard occlusal appliance for 60 days led to reduction in the clinical signs and symptoms of temporomandibular disorder. With that, I mean orofacial pain in patients that are sleep bruxers. But when looking at the electromyographic results for the same patients, we can see that the occlusal splint did not present any significant difference before and after treatment regarding to the muscle activity. So in a patient with an important amount of tooth loss due to bruxism, we can build those teeth again by usual dentistry materials. However, if this patient is still grinding, what's usually the case, those treatments will not last long. So we need to use an occlusal appliance again to protect that restoration from further damage. So that's another indication for using occlusal appliances to protect new dental treatments that were done against the consequences of bruxism.
Okay, we're going to switch back to some more medical conditions here that can be associated with sleep disturbances in older adults. So first I want to talk about anxiety and depression. Now, both anxiety and depression have implications for sleep. They can either interfere with sleep induction or sleep maintenance. Anxiety often precedes insomnia, whereas with depression, insomnia often occurs along with or after the depression comes along. So one of the reasons I link these together is because we tend to use antidepressants both for depression and anxiety symptoms. However, when dealing with sleep disturbances associated with these conditions, we do have to understand some of the properties of the various antidepressants in order to select the best one and to make sure that we administer at the best time of day. I think most of us working with older adults have seen trazodone and even mirtazapine ordered as a sleeping aid. These are classically known as antidepressants, but I think they tend to have more use these days as to help people calm down or sleep. There is, in fact, limited evidence for this indication. However, a lot of clinical experience using these agents in this way, and I know we've used them. It is important to remember that when we use mirtazapine is different than trazodone in that mirtazapine tends to be more sedating in lower doses, so doses of 15 milligrams or less than the higher doses. So often 7.5 milligrams of mirtazapine can be very sedating, whereas if you'd give more than 15, say 30 milligrams, it may not be as sedating. That is not true of trazodone. Trazodone tends to be more sedating with higher doses. It is important to realize that when we use SSRIs, and SNRIs, so the selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors, things like citalopram, escitalopram or Lexapro, fluoxetine, sertraline, venlafaxine, those kinds of antidepressants, they can actually be activating in some patients, and they can actually interfere with a person's ability to fall asleep. So we may need to give those earlier in the day. And oftentimes when we're recommending those drugs, I will tell people, I said, these drugs they can either make you tired or they can, keep you awake. So you kind of have to see how you react to them and then dose them accordingly. Sometimes we give them at bedtime, sometimes we give them in the morning. Bupropion, which I mentioned earlier, is kind of a different mechanism of action. It works more in the dopaminergic system and tends to be more activating. In fact, we like to use it as an activating antidepressant for people that need some activation, and that should not be given at bedtime because of that. One thing that I do want to mention is that we should avoid benzodiazepines. Even though benzodiazepines are clearly indicated for anxiety, as I mentioned earlier, benzodiazepines tend to be very problematic in older adults. They have indications for insomnia and anxiety, but that risk-benefit analysis that we have to do when we want to prescribe a medication tends to fall in the more risky side for these medicines. The risk of falls alone would definitely make me worry about a person taking benzodiazepines every night, especially getting up at night and walking after taking these drugs. And also they are associated with cognitive impairment. And we have a couple observational studies that suggest an association between benzodiazepines and the development of dementia. So let's talk about asthma and COPD. With asthma and COPD, how they interact with sleep is that when people lie down, it often will induce an exacerbation of either their asthma or their COPD. These symptoms flare up, and this can often be a manifestation of poor disease control. Again, I've linked these two conditions together not because they necessarily are co-occurring in people, but they tend to have similar effect on a person's ability to sleep. So let's talk about asthma first. So certainly nocturnal symptoms may suggest inadequate control. So if a person comes in saying that they cannot sleep, they lay down, they start wheezing, they can't catch their breath, that should alert us that maybe their maintenance therapy isn't quite right. So we need to do an evaluation of that. So one of the first things we're going to do is always say, well, how many doses of your as needed or your PRN medication are you using? And since most people use some form of albuterol or a short-acting beta agonist as their PRN use, we also have to realize that drug, being similar to epinephrine, tends to be very activating, and it tends to make people nervous and jittery. So, certainly taking that when you're trying to sleep is not going to really help you sleep. So being aware that they're overusing their as-needed medication because their controller medication, maybe their long-acting or their inhaled corticosteroid is not dosed properly, or they're not taking it, which is often the case, can be a clue as to which direction we should go. Another option, if we've optimized the dose and the inhaled corticosteroid, and we still are having nocturnal symptoms, we can add another drug called Montelukast or Singulair. That tends to be dosed once a day at bedtime, and it is a fairly effective medication to add to the maintenance medication. Similar to COPD, or similar to asthma, when we have patients that have COPD that tell us they can't sleep, they have to sleep in the recliner, they have 5 pillows under them, they can't lay down flat, we should start asking them again about their use of as-needed medications, and certainly consider that maybe their maintenance regimen is not appropriate, maybe they aren't taking it, maybe they can't afford it. We do have to realize that many of the inhalers that we use for COPD are very, very expensive, several $100s a piece. And especially for folks that have Medicare, once they reach that donut hole where Medicare is not going to cover the same amount of dollar value of their prescriptions, they may have to reduce the dose or stop taking them. So asking about adherence, finding out, are they taking their maintenance inhalers? Some people still struggle with understanding, the maintenance inhaler versus the as-needed inhaler. So working with them to optimize their therapy based on these complaints is always the first thing we want to do. Certainly pulmonary rehab and smoking cessation are clearly beneficial, even regardless of sleeping problems. We should always be working with our patients with COPD to encourage rehab and smoking cessation because they can certainly help with managing the control of that disorder. Optimizing long-acting anticholinergics such as tiotropium is recommended. And don't forget, sometimes as the disease progresses, we need to consider the use of supplemental oxygen. Let's talk about GERD, gastroesophageal reflux disease, often referred to by its prominent symptom of heartburn. Many times patients will say, I lay down at night and I just feel like this acid is coming up and I get, this horrible, taste in my mouth and I can't sleep, it hurts. I take Tums and it lasts for a little while, but it doesn't last very long, and it wakes me up in the middle of the night. Many times this is associated with maybe eating too late in the day, where the food hasn't had a chance to really get out of the stomach, so that you're getting reflux of the stomach contents, and that includes the acid, which our stomach naturally has in it, into the esophagus, and this causes pain. So nocturnal GERD treatment, initial management should always involve lifestyle modification. I mentioned just a moment ago that eating late in the day, eating certain foods, there is association between tomato-based foods or other spicy foods in bedtime, increasing one's chance of having nocturnal GERD symptoms. So the lifestyle changes should definitely occur, and even if they don't 100% alleviate the condition, they should be maintained even if we need to go to pharmacotherapy. However, many times the non-pharmacological lifestyle changes are sufficient to take care of the symptoms, and these include things we've all heard of, like weight loss, not eating late at night, raising the head of the bed, putting it on some blocks, and just trying to work through this without medication. If, however, lifestyle modifications do not 100% take care of the problem, we can certainly consider pharmacotherapy. Now, this is an area that has changed in the last year or two. So I know a lot of people say, GERD treatment, okay, everybody knows how to treat GERD. You put them on a PPI, right? You put them on omeprazole or Prilosec. They're over the counter. And in fact, many people self-treat, and the providers don't even know they're using them unless we do a complete medication history and reconciliation, which we should be doing at every visit. But since these agents are over the counter, we may have people self-treating, and we don't even know about it. So in the past, we would usually start a person on a PPI, omeprazole or Prilosec. Nexium, esomeprazole are commonly used. And the reason we would use that is they're very effective. They really are good at reduction of stomach acid. However, I'll talk in a moment about why we're not so keen on that idea right now, as we have been in the past. We can use antacids. Our case, MB, is using Tums. Tums is calcium carbonate, and it is an antacid, so it's different than a PPI. A PPI is going to actually shut down the acid pump that pumps acid in the stomach. An antacid actually takes the acids there and it neutralizes it and kind of makes it more basic. So it's not as potent, it doesn't last as long, but for occasional symptoms, if a person comes in and they say, well, yeah, every time I go to that New Mexican restaurant and eat, and we're there and we have a couple margaritas, I have nocturnal heartburn, well, that might be a good night to just, take a dose of a PR, an as-needed antacid like Tums or Vylanta or something, because you're pretty much going to predict that you're going to have that symptom. The disadvantage of the antacids is that they have a fairly short duration of action. Now, another option is what we call the H2RAs. These are commonly known by the names ranitidine or Zantac or famotidine or Pepcid. And these can be used both on an as-needed and a preventative or maintenance basis. They do have a longer action than the antacids, but they do take a little bit longer to work, so they don't work quite as fast as the antacid. I will point out an older drug that we used to use a lot to help speed food as it's going through the GI tract, which was Reglan or metoclopramide. We generally don't use that today due to some of the pretty severe adverse effects. It's an antidopaminergic agent, and it causes a lot of extrapyramidal side effects similar to the antipsychotics, so it's a little something we really don't want to use. So you maybe heard the term step-down therapy or step-up therapy. We're going to talk about step-down therapy first. So remember I said a lot of times people would maybe just start with a PPI like omeprazole, Prilosec, Nexium, esomeprazole, because it's most effective. And some people still do that. I'll talk in a minute again why we don't necessarily always do that now. But step-down therapy is described as when you initiate the highly effective drug, so the PPI, to get control of the symptoms, to kind of just knock that GERD out. And then as the symptoms become controlled, we do what we call a step down. And we step down to a less potent agent, so something like maybe an H2RA, such as ranitidine or famotidine, so that we don't have to keep the patient on the more potent PPI for long periods of time. So why are we trying to minimize the duration of time a person's on a PPI? Remember, PPIs are omeprazole, Nexium, Prilosec, those kinds of drugs. For years we didn't worry about this. We put people on these drugs, and if they worked for them, we just kind of left them on. The FDA at some point decided they were safe enough to go over the counter, so they went over the counter, and they're just a huge market for these drugs because of people's stomach upset. We're now finding increasing concerns about the long-term use of these drugs. There's growing evidence that this extreme suppression of acid in the stomach may cause some problems. And I've listed on this slide some of the problems that have been clearly associated with PPIs, and some that are just coming to light. Probably one that we've known about for some time now is the association between C. difficile infection. And if you think about it, it kind of makes sense. We have an acidic environment of the stomach because, quite frankly, we put things in our mouth that are dirty. We have bacteria in our foods and other things, and that acidicness of the stomach is a very good barrier to that. If we don't have that acid, we can actually run the risk of having some infections. So C. diff has been associated with that. Pneumonia, again, getting some of the reflux of those the bugs that get in our food and getting reflux into our lungs can cause pneumonia. Certainly malabsorption of calcium. We first started noticing in some observational studies that people on PPIs were increased risk of having some osteoporosis and fractures. And if you think about it, certain forms of calcium carbonate, of which Tums is calcium carbonate, as well as many of the calcium supplements people take, calcium carbonate is not very soluble, and it actually has to have an acidic environment to be solubilized and absorbed from our GI tract. So if we have a non-acidic stomach, those calcium pills are just going to stay together and probably not get absorbed. So that has been identified as one of the biologic reasons why PPIs are associated with osteoporosis and fractures. There's recent data on kidney disease, dementia, and so there's a lot of reasons why when people come into clinic nowadays on these drugs, we're talking to them about how long have you been on that? Are you willing to try step down? Let's try some Zantac or some Pepcid and see if we can get by. Now, I will warn you that when you stop a PPI, people are going to have rebound hyperacidity. So you can't just stop them cold turkey. You need to either taper them or you need to be gradually replacing them with another kind of acid suppressant like ranitidine or famotidine. Because stopping a person's PPI after long-term use, you're going to have rebound, and they're going to want that drug back. So let's talk about generalized pain now. So not so much heartburn, but just the chronic and acute neuromuscular pain that so many times people develop as they age, due to wearing out of joints, neurotoxicity from diabetes and other conditions. So, I think everybody that's had a headache or any kind of pain, regardless of their age, knows that, sometimes, that can really interfere with your sleep. And this underlying cause for this pain in older adults is often osteoarthritis, the wearing out type of arthritis where joints are, maybe bone on bone and inflammation or pain is present in those joints. However, often the chronic pain can be from neuropathic disorders such as peripheral neuropathy, which is commonly associated with other disorders in the older adults such as diabetes. So we do need to always be assessing for pain and seeing if we can try some appropriate strategies to address that. So for general arthritic pain, acetaminophen remains the first option in most guidelines, although there was a recent study not too long ago that talked about how acetaminophen may not be as effective for osteoarthritis as we once thought, but I think most of us still feel that's the first place we go. For a couple reasons. It's relatively safe as long as we maintain the dose at less than 3 to 4 grams a day. Some people go 3.2, some go 4, and either one I think can be reasonable depending upon the pain level. But I will tell you, if you do go to 4 grams per day, we should be alert for hidden acetaminophen and other over-the-counter products. Remember, people can self-treat with a myriad of over-the-counter products, everything from allergies to cough and cold remedies, many of which, when you look at the label, have fairly high doses of acetaminophen, sometimes 500 to 1,000 milligrams per dose. So if you have somebody maxed out on the 4 grams of acetaminophen a day, and they get a cold and they start taking some of these multi-symptom cold products, they're going to be over the 4 grams a day by maybe a gram or two, depending upon how many doses of that cold medicine they take. So you do need to be aware of those hidden sources of acetaminophen. As far as opioids for chronic pain in older adults, non-cancer pain, we generally try to avoid them. There's many reasons. I don't think anybody, unless they've had their head in the sand for the last 5 years, has been should not be aware of the dangers of opioids and how we should just be a little bit more judicious in how we recommend those and prescribe those. They have many negative side effects. There's a lot of toxicity. There's overdose. There's, of course, diversion issues that we're dealing with right now. And opioids actually have a negative effect on sleep architecture. So, they tend to be sedating, but people don't get that good restful sleep that they need when they take opioids. So what about neuropathic pain? So, I talked about osteoarthritic pain. We tend to use Tylenol as an initial choice. Neuropathic pain, we tend to use gabapentin. Gabapentin's been around for a long time, brand name Neurontin. It's generically available, it's relatively inexpensive, and it's been shown to be pretty effective at appropriate doses. It may actually, a couple studies have suggested that gabapentin might improve sleep architecture. So for many of us, the first choice for neuropathic pain is going to be gabapentin. Well, this drug is not without side effects as well, but as long as we slowly taper a patient or a person up to the target doses, most people can tolerate the drug, and many will see benefits. So when I say taper, this drug is fortunately available as a 100 milligram capsule, and many times when we recommend it in our clinic, we'll start people out as low as 100 milligrams a day at bedtime. And we'll gradually increase that to 100 milligrams twice a day, after a few days, then 3 times a day. And we'll work up to, and you can go quite high on this, keeping in mind, however, that you do need to get an assessment of renal function before you initiate gabapentin, because gabapentin is about 100% renally cleared, and we do have very strict dosing maximums depending upon levels of glomerular filtration rate. So we will lower the dose and we will extend the dosing interval depending upon where a person's renal function is. So using gabapentin is pretty easy. You have to taper it, but you do always want to make sure you know where the person is with their renal function. The side effects of gabapentin are serious if we're not careful. Dizziness, falls, and cognitive impairment are the ones that we tend to be most worried about, because those are all side effects that we do not want to induce in an older adult, and those are things that we should take very seriously, and we should be monitoring anytime we initiate therapy and start treatment. Another option for pain is duloxetine or Cymbalta. Now, we used to think of it primarily for neuropathic pain, although now recently it's gotten an indication for lower back pain and osteoarthritis as well, and it's used for fibromyalgia. Duloxetine has a kind of a unique duration of action. Gabapentin is more of a classic anticonvulsant. Duloxetine is more related to the SNRI antidepressants, and there's a mild effect on dopamine reuptake as well, but primarily we think of it as an SNRI antidepressant. But it tends to have a little bit more of an effect on pain than some of maybe the other ones, or maybe it's just been studied more, but it's certainly used a lot more. But having said that, you could use the other SNRI antidepressants like venlafaxine for pain as well. Pain also often has a mood component, and we often find it helpful in older adults to address that mood component, and this drug tends to do both. It tends to address the mood as well as the pain. So as I mentioned, this is an SNRI antidepressant, and it affects both serotonin and norepinephrine. And because we're affecting those two neurotransmitters and we're actually elevating relative levels of that in the central nervous system, it can be an activating drug. So it can maybe keep people at night. Some people actually experience insomnia if this is taken late in the day, whereas other people get drowsy from it. So it's one of those kind of paradoxical reactions that, when you look at the side effect profile of this in any reference, it'll say can cause insomnia, can cause drowsiness. When you think, how can that happen? Well, it can be that way in different people. So we tend to tell people to try taking it. I often tell them to try it in the morning first, see how it works for them. If it makes them kind of drowsy during the day, try taking it at night. And as long as they take it at approximately the same time every day, they should be fine. So gradually, figuring out what time of day it works best, which side effect predominates. One other side effect that we do need to counsel with this, and we really should be counseling with all of our SNRI and SSRIs, is the side effect of nausea and vomiting, and taking it with some food. Okay, this brings us to benign prostatic hyperplasia, or BPH, which is a fairly common disorder in older men. So, it involves the prostate getting larger as we age, and the anatomy of our lower urinary tract is such that the prostate, when it gets larger, will press against the urethra and basically prevent the bladder from fully emptying. So the person will go to the restroom, feel like they got their bladder partially emptied, and there'll still be quite a bit of urine left in the bladder. So it results in urinary frequency and often urinary urgency. And this, of course, as you can imagine, going to bed at night, you go to the bathroom, you urinate, you go to bed, maybe 2 or 3 hours later you have to do it again, maybe 2 hours later you have to do it again. So you wake up multiple times a night, and sometimes you have a hard time falling back asleep. So whenever I'm talking with my older gentleman patients about this, one of the big questions I ask to find out how their BPH is being controlled, because we certainly have some medications we're going to recommend for this. One of the big questions I ask is, how many times do you get up to go to the bathroom at night? And then the follow-up question, how difficult is it for you to fall asleep after you get up to go to the bathroom? Because those two questions will pretty much tell you everything you need to know. So how do we treat BPH? Well, certainly not with a sleeping pill, because then we would probably just have incontinence. Dosing, so we basically use selective alpha receptor blockers, and we tend to give those in the morning. We give those in the morning because they tend to last about 18 to 24 hours, and giving them in the morning will result in good bladder emptying throughout the day. So when they go to bed, their bladder is fairly empty, and many times they can sleep all night. Now, some of you might say to me, well, gosh, I remember when I was first learning about alpha blockers, I was told we always give them at bedtime. And we did. We actually did. Before we had the selective alpha blockers, things like Flomax, tamsulosin, and we had drugs like terazosin and doxazosin, we always gave them at bedtime. Not because pharmacologically that was the best time to give them, but because of the side effects. The non-selective blockers, the terazosin, doxazosin, they cause a lot of lightheadedness, dizziness, and even oftentimes what we used to call first dose syncope, where people would just pass out because of the fact that they would dilate vessels all over the body, and you would actually have blood shunting out of the brain, which would cause people to pass out. So we tended to give those drugs at night, at bedtime. Unfortunately, when the new drugs came out, we kept telling people to give it at bedtime, and it's been one of my missions is to get people to give those selective alpha blockers in the morning, so we can get that bladder emptied, and we can have a good night's sleep. Finasteride is another choice, Proscar, which is an option. Finasteride will actually shrink the prostate, which is a different mechanism of action than the alpha blockers, which actually just open up the urethra better. I generally don't start with finasteride for a couple of reasons. One, it takes about 6 months to work, and people have to be pretty patient for that. And it has a side effect profile that involves some sexual dysfunction that many people do not like. Dementia. So dementia is a fairly common comorbid condition in older adults. Now our patient, MB, did not have dementia. She was cognitively intact. But assessment for dementia is always appropriate when people have sleep concerns. And with dementia, there's often other comorbidities that we should be addressing before attempting any kind of pharmacotherapy for sleep. Any of the sleeping pills that we would use for a person with dementia are going to make things worse. They're going to negatively affect their cognition. They're going to have more problems with getting up at night and wandering and doing, having behaviors. So the sleeping pills are not a good idea for a person with dementia. So we really need to be a little bit more creative. Now, with dementia, and this goes for things other than sleep, we do need to remember that the behaviors a person with dementia may display can give you a clue as to what their comorbidities are. What is that behavior trying to tell you? So if a person is, agitated at night or even during the day, that could be their manifestation of pain, for example. So trying to assess for these comorbidities and understand the underlying reason for the behavior or the symptom, in this case the insomnia, is super important. It can be a little more challenging with dementia, but there are ways. There are ways to identify this unmet need. So treating the comorbidities, we've pretty much covered most of those. Identifying those, as I said, can be more difficult. But for example, pain. If pain is a comorbidity, possibly the person with dementia cannot use a traditional pain scale. If you ask them on a 1 to 10, what their pain is today, they may not be able to verbalize that to you, or they may not even be able to point to a facial scale. In those cases, we have to look at body language. If you touch them in a certain area and they grimace, that's an indication of pain. So oftentimes we have to use a little more creative measures to assess for some of these comorbidities. Pain is the example I used. So I've already talked about most of the other treatments for comorbidities, so I will discuss some treatments here for insomnia associated with dementia, but I want you to be aware that the strategies we're talking about from here on out are also strategies that have been shown to be effective not only in dementia but in other patients as well. So cognitive behavioral therapy, or CBT, has been studied in older patients, not so much with dementia, but older patients in general. And a recent study came out, and some recent guidelines have come out that have really endorsed CBT as a very good first step. Stimulus control includes minimizing non-sleep activities in the bedroom, such as watching TV and using the internet. Many times now that we have these portable tablets, people are in their bed watching, Sports Center at night or whatever you're doing, and that's all activating stuff, and it interferes with our sleep, so minimizing that. Sleep restriction involves minimizing daytime naps and reducing time in bed while not sleeping. Cognitive therapy includes addressing maladaptive beliefs about sleep. So the idea that I should be able to fall asleep within 2 minutes, and I should be able to sleep 8 hours every night, that just may not be true anymore. And some of these maladaptive beliefs about the consequences of not sleeping the way they slept when, say, they were 16. Now, for this total package of CBT, it really requires a provider with training, time to spend with the patient, and truly a patient that's fairly cognitively intact. So for the patient with dementia, some of these things just aren't going to be possible. But some of them, the caregivers can help address, like minimizing the distractions in the bedroom. Okay, sleep hygiene. I think most of us have heard about sleep hygiene, and really educating the patient or the person with a sleep disorder about sleep hygiene can be done fairly quickly, and most people can understand how to implement these changes. Whether or not they choose to do it is always the question. So listed here on this slide are some of the components most of us try to incorporate in a discussion with our our patients about sleep hygiene. Of note, avoidance of excessive light before bedtime includes light from computers or tablet devices, which many people use before bedtime. A lot of people like to do their reading on a Kindle or a tablet, and some of the newer versions have special settings that are less interfering with your sleep than others. But being aware that that is light and that can actually change our ability to fall asleep is important to educate patients. So where is the evidence for sleep hygiene? So in patients with dementia, we have limited evidence. It's just really, really hard to study this. It's hard to incorporate cognitive behavioral therapy and sleep hygiene in patients with dementia. However, there are certain aspects that we can do, like minimizing activities in bed other than sleeping. The caregivers can have a big role to play in this. So limited evidence, but because of the lack of any toxicity from sleep hygiene, I think most of us are very, very willing to try anything that we can. In patients without dementia, again, we do have more evidence. It's pretty sparse still. I think most of us think the recommendations are theoretically sound, and they're just basically good practices for all of us. We all should probably practice sleep hygiene. Again, the risk is minimal, so most of us are going to recommend it and try to encourage our patients to at least incorporate parts of it. Even if trying to get them to agree to a standard bedtime, that's a big issue for people, and not, making their bedtime vary by 4 to 5 hours per day. Sometimes they go to bed at 10, sometimes they go to bed at 2 in the morning. I mean, that's just not a healthy bedtime, especially as we age. Addition of physical and social activity. This is something that can be implemented for patients with dementia as well as those without dementia. The studies overall have shown a neutral to positive effect on sleep for these strategies. This strategy of getting physical activity during the day so that maybe tires a person out so that they sleep better at night. I mean, it fundamentally sounds reasonable, and it really seems to work. Social activity as well, having social contacts, not being alone all the time. Remember our case that we had, MB, she lives alone out in the country in her farmhouse, so I'm not sure she has a lot of social interaction. Certainly working out on the farm can be a lot of physical activity. However, I'm not sure she's doing a lot of that activity. And sometimes being isolated out in the country, especially if she doesn't drive, she probably can't go to places maybe where she can safely walk and get some exercise. So thinking about where a person can get this social and physical exercise can be a challenge. Bright light therapy. So many of us have seen those light boxes that people have at their desk, and it's been used for a number of conditions. Some people think it helps with seasonal affective disorder, depression, and those kinds of things. The studies are kind of sparse and not showing a lot of super good benefit for bright light therapy. But again, it's relatively harmless therapy. The studies that have shown some effect on helping people with sleep disorders have shown that the bright light boxes early in the day tend to be possibly effective. Again, the evidence is pretty sparse, but again, it's a pretty harmless therapy, and it might be worth a try. So what about other pharmacotherapy options? I've pretty much given you my thoughts on the drugs that we currently have that are marketed as sleeping agents, the Zolpidem, Ambiens, benzodiazepines, and such that are probably a little too risky to use, especially in the older population. But we do have a couple other options. Melatonin, which is an over-the-counter supplement, has been used for years for sleep problems. It is also used for jet lag. And there's actually some studies that point to that being possibly effective for that. Most of the studies and the evidence point to this drug being useful to decrease sleep latency, so helping a person fall asleep faster, but not necessarily shown much effect on the overnight awakenings and keeping people asleep longer. But again, for most people, they have minimal side effects to this supplement. and it's relatively inexpensive. It's available over the counter. And by the time people come to us, many people have already tried it. And either it obviously didn't work or they wouldn't have come to us. But melatonin's out there, and I think a lot of people are pretty comfortable recommending it as a trial. Ramelteon is a prescription drug, also known as Roserum. It is a melatonin receptor agonist, and this is a much like a super melatonin, if you will. It works right on the melatonin receptor in the brain. It's definitely safer than like the other marketed prescription drugs for sleep. However, the data out there on its effectiveness is marginal and limited. So I don't recommend this very often unless it's kind of a last-ditch effort. And the main reason is only available as the brand name, and it's like hundreds of dollars a month. So it's a very, very expensive agent, and I'm just not convinced with the limited data on its effectiveness that it's quite worth that. So let's head back to our case. We're going to finish up here talking about MB, and this is just another slide it's a repeat of the one at the beginning of the presentation to remind us about MB. Remember, she's a 74-year-old female. She lives alone at her 2-story farmhouse out in the country. And she has this problem sleeping, and remember, she wanted a sleeping pill, but we weren't too excited about doing that. Her medical conditions there, remember she has hypertension, treated with a couple meds there, osteoarthritis that she uses OTC ibuprofen, and then GERD, which she uses OTC Tums. So what should we do? So certainly getting a good thorough history and assessment of what's going on here is important. So finding out maybe doing a depression assessment. We tend to use the geriatric depression scale. Finding out that that she's taking all that ibuprofen is important, because I think that should kind of point to us that this pain is probably a big component of her sleep problems. The GERD as well. Remember I said with antacids like Tums, they tend to be fairly quick acting, but they don't tend to last very long, so maybe she's not getting good results from that. Certainly realizing that GERD symptoms can be exacerbated by the use of ibuprofen. Ibuprofen is very injurious to the gastric lining, and it causes a lot of pain. So, and it can cause ulcerations and even GI bleeds. Finding out when she's taken the hydrochlorothiazide, which is a weak diuretic. I know we don't tend to think of it as causing a lot of diuresis, but some people it does. However, when talking with her, she was taking it in the morning, which is the appropriate time. And again, checking for depression, of which she did not flag for depression using the geriatric depression scale. So for MB, we'd probably have a couple things we could recommend. Certainly education about her sleep. Talking to her about changes as we age, asking her some questions about when she falls asleep. Is she willing to set a set bedtime, whatever is a reasonable time for her, and a set awakening time? Is she willing to limit her activities in her room, not doing a lot of reading or computer work in her room if she does? Suggesting getting some physical activity, finding out, is there a safe place that you can go out and walk? Maybe if she's living out on a gravel road with a lot of traffic, it isn't safe for her to walk. Finding out if she has transportation to maybe go to a city park or a city place where she has friends and maybe can do some walking, and while she's doing that, have some social interaction as well. Now, her osteoarthritis pain treatment is probably going to be a concern. Getting physical therapy involved can do a couple things. They can help, give her some exercises to relieve some of that pain, and they can also help her with her exercise training. As for pharmacotherapy recommendations, the first thing we want to do is discontinue that ibuprofen. I don't believe that older adults should be on chronic NSAIDs such as ibuprofen unless it's absolutely necessary. Certainly an occasional dose for a headache, or maybe from doing too much out in the yard or something like that, is probably not going to be devastating to most people. But chronic use puts a person, especially MB, at severe risk of GI side effects, She already has GERD. The ibuprofen can certainly be exacerbating that GERD, but it also puts her at increased risk of having a GI bleed, which in her case could be fatal. She's living alone, remember. If she bled through her gastrointestinal tract, she could, not survive that. So a very, very serious condition for her. Also remember she has hypertension, and we know that NSAIDs such as ibuprofen are associated with kidney effects resulting in increased sodium and water retention, raising blood pressure and increasing her cardiovascular risk. So with hypertension, she already has that risk, her heart's at risk. We're actually adding to that risk by putting her on ibuprofen. So we would recommend going with the gold standard, the beginning treatment for osteoarthritis, which is acetaminophen. We could dose that at 500 milligrams to 1,000 milligrams up to 3 or 4 times a day. Remember, we want to keep our dose down to about 3 to 4 grams a day. I tend to start with the lower dose so that people can have a dose to give as needed during the day if they wanted. So 500 to 1,000 3 times a day would probably be where I'd go. That way, if they took another dose, they'd still be under the 4 grams. We'd want to monitor the GERD symptoms and just see how much of her GERD was due to the fact that she was taking such high doses of an NSAID, ibuprofen. If the GERD symptoms continue, we could try step up or step down therapy. Probably, depending upon her symptoms, we might want to step up from the antacid to maybe an H2RA, such as ranitidine or Zantac. I probably wouldn't start her on a PPI right off the bat. I'd like to see if we could manage her on a less potent agent, so we don't just get her started on the PPI and have a hard time getting her off of that. And the final recommendation for MB, no sleeping pills. I don't think that should surprise anyone that they're not going to recommend a sleeping pill at this time. I think in her case it would be extremely risky. Remember, she lives at home in a 2-story farmhouse. The last thing we want her to do is to be getting up in the middle of the night, not remembering it, going down the steps, falling down the steps, or worst case scenario, walking outside and being injured in the weather or outside and being found out in the yard a couple days later. So definitely no sleeping pills for MB. If the Tylenol was not effective, what would be a good alternative? At this point, remember, because of her osteoarthritis pain, we could try duloxetine. Duloxetine is now indicated for osteoarthritic and lower back pain, so we could try duloxetine and see how things go. In conclusion, I would want to say that hopefully through this presentation you've identified that reduction in sleep quality as we age can be a common complaint, and it can certainly negatively affect quality of life as we age. Treating these conditions as symptoms of perhaps an underlying condition should always be the first step in addressing these concerns. And I hope that this information will help you as you develop your holistic approach to managing sleep disorders in older adults. Thank you very much for your attention.